Hey guys, can you see me? Can you hear me? If so, say me hi and hello. Hey guys, good evening. Hope I'm audible and visible. Am I audible, visible? If so, say me hi. So welcome back to PW Medit once again. So will be going quickly towards a few important images which came in the last previous years of NEET PG, and we'll be just quickly going through it. I'll be conducting kind of two sessions. One, I'll be going with like 25 images in this session. Quickly, just the pointers for diagnosis, and I'll be asking tiny questions, and I want you guys to answer for that, right? And then we'll definitely go towards hematology and the rest of it in the next class, right? So you're ready as usual. Let's go for the game. So this was a question which came. I'll give you a brief introduction about this history which came along with this question. The patient was a smoker and this was a bronchial biopsy. Can anyone tell me the right answer? I might point this also for you guys. So this is a normal structure here. Okay. The normal structure is on the left hand side, and the right hand side we have the perfect. Your drug of choice has gone with metaplasia. Can anyone add on to anyone add on to it? Dr. Jain has gone for metaplasia as well. Can anyone say me what type of metaplasia it is? What type of metaplasia you will call this, right? So this is definitely the normal part, and this is obviously the metaplastic part, right? Perfect. This is a classical case of a squamous metaplasia, right? Seen in which patient? This is a classical case of squamous metaplasia, and obviously you'll be seeing squamous metaplasia in case of a respiratory epithelium in patients with smokers. Can anyone give me one more example of metaplasia which happens in the esophagus, which is Barrett's esophagus? What type of metaplasia is it microscopically? Hello, Vansh. Great going. It is the most common type of metaplasia. Your drug of choice, you're absolutely right. I told it's Barrett's. I want you to tell me what's the microscopic kind of metaplasia you see in Barrett's. Perfect, it's columnar metaplasia, right? Amazing. So this is an image of squamous metaplasia where you have this normal, can you see the tiny cilia here? Tiny projection cilia here, and this part here we have the squamous epithelium, right? Multiple stratified squamous epithelium changes from a pseudo stratified columnar epithelium, right? Perfect. Let's go to the next question. We'll be just going towards classical diagnostic point of images. Will not waste your most important, valuable and precious time here. Next image here, I want you to tell me what you are looking at. This is a cardiac biopsy, and what does this mean? What are these? What are these? It's a cardiac biopsy of, let's say, a 70-year-old person. Hello, Rahul. Good evening. Perfect. That's a lipofuscin, right? Perfect. So the lipofuscin pigment, it's a brown color pigment. I want you to fastest finger first. What? Yes. Good evening, Priyanka. What is the location of lipofuscin in a cell, or what's the clue for diagnosing lipofuscin, right? It's a wear and tear pigment, right? Perfect. The clue is it'll be peri or your paranuclear location. It'll be in and around the nucleus, and this is the electron microscopic image, because previously lipofuscin has been asked in light microscopy. So if we change to an electron microscopy, this is my nucleus here, and you can see the striations here. These are the muscle fibers here. I hope you can appreciate the striation, and these pigments on either side of the nucleus is your lipofuscin pigment, right? Perfect, right? Can anyone comment here on any other type of brown color pigments you see in microscopy? Great, Yamini. Any other brown color pigment you see in microscopy? Other brown pigments? Perfect. You have melanin, which is a brown pigment. Iron or hemosiderin is a brown pigment, and also copper is a brown pigment, right? Perfect. So let's take melanin again quickly. Hemosiderin is a brown pigment, and again copper is a brown pigment, right? Perfect. I want you guys to comment on what is the stain for hemosiderin. This has been asked previously, and I'm sure you know that copper is in Wilson's, right? You have your Pearl's Prussian blue or just your Prussian blue stain, right? I have one more leading question to this because the PYQ, let's extrapolate a little bit more. Pearl's Prussian blue will stain hemosiderin, ferritin, or both. What will be the right answer? What will say? Pearls will stain both hemophirin, ferritin, or only hemosiderin, or only ferritin. Pearls will stain, remember this, it will stain only hemosiderin, and it will not stain ferritin. Ferritin is a physiological part of iron which will not be stained in hemosiderin. It will not be stained in pearls. Only hemosiderin will be stained. Only hemosiderin. Just do remember that, right? I think someone answered the next question thinking that I'll ask for stain for copper. Yes, rubionic acid is stain for copper. I want you guys to name any other stain apart from rubionic acid and something which does not start with an R. I'm sure that you will say rhodamine next. Any other stain? We have stain called an Orsine stain. Ornstein stain is a stain for copper, and that, like someone previously said, I can see them in Wilson's disease, right? Since we are in the topic of Wilson's disease, what is the finding you see in the eye in case of Wilson's disease? Though it's not my subject field of interest, but I'm sure this is a PYQ topic and I'm sure you know that, right? It's your classical KF ring. Perfect. Can anyone complete this? Melanin, what is the color of melanin? Brown color microscopy. Can anyone tell me one important stain which can pick up melanin? Once, like I said, only KF ring, I know, you might be right in bullseye retinopathy. Fine. Perfect. You have your Masson-Fontana. Okay. So Masson-Fontana is a stain which can be picked up, which can pick up melanin in a microscopy, right? Amazing. Okay. So I'm going to ask one more leading question related to Masson-Fontana. There's one more stain which has Masson in its name. What is that? Rishabh, I think we will discuss about these things later. These are for NEET PG exam going students. We'll quickly cover things. It's Masson's trichrome. Great. In Masson's trichrome, as the name says, there are 3 colors, right? What will be the color of collagen in case of a Masson's trichrome? You guys are right. It's Masson's trichrome. What will be the color of collagen? Collagen will be blue in color, right? Blue color will be for collagen, the 3 colors. And if you want to know the other colors, red color will be for the muscle part, and black color will be for the nucleus part, right? So these are the 3 colors which is seen in Mason's trichrome, right? Amazing, great. Let's go to the next question. This is a spotter. If anyone can give the right answer, let's see if anyone can give the right answer. This is spotter. I'll give you a clue also. This is a 5-year-old person. It's amazing. You have the classical. It doesn't look like a wrinkled tissue paper, but I'm sure you have used to seeing these images seen classically in Gaucher's disease. Fine. Okay. So Gaucher's disease will have wrinkled tissue paper appearance. In addition to Gaucher's disease, you will also have Niemann-Pick disease, which can also have macrophages, storage macrophages in your bone marrow. How do you pick up Niemann-Pick disease bone marrow? Because if I have Gaucher's, I have this color, definitely can pick it up. If it's Niemann-Pick disease, what is a clue? How can you pick up Niemann-Pick disease? Please do remember, Niemann-Pick disease, the macrophage will have a tiny bubbly cytoplasm. If it has very tiny, bubbly, clear cytoplasm, that's how a Niemann-Pick disease looks like. That can also have the same history, storage disorder, which can involve the bone marrow, sphingomyelin deficiency. It'll have very tiny bubbly cytoplasm. Zebra bodies is in your electron microscopy, right? Jane and Bharat, zebra bodies, I won't see them in a light microscopy. In light microscopy, the only thing I'll be seeing is your fat accumulation. That's what I'll see, right? Yes, Gaucher's is definitely pH positive, as fat accumulation, right? Please clear that. You won't see zebra bodies in a light microscopy, you see them in an electron microscope, right? Let's go to the next question. There's a clinical correlation here. This is a patient with a swelling here, okay, and in this region approximately, and this is a microscopy. I'll give you a clue. This is a lip biopsy. Okay, there's also MCQ for you. Lip biopsy and a swelling here. What will be the diagnosis? Okay, and Das has gone with pleomorphic adenoma. Pleomorphic adenoma. Okay. I'll give you one more clue. Yes, clinically it's right to call it pleomorphic adenoma, but microscopy I don't have a cartilage, so I don't think of an adenoma. This patient also had dry eyes. Can anyone tell me the answer? Dry eyes, salivary gland swelling, and microscopy has these structures. That's your classical history of Sjogren's syndrome, right? Not sarcoid, Sjogren's syndrome, right? Perfect. See, pleomorphic adenoma also can have the same history of swelling of the salivary gland, but in pleomorphic adenoma, please do remember, if this question comes in the exam, in case of a pleomorphic adenoma, you will see cartilage. And I'm sure everyone knows how to pick up a cartilage. You see a cartilaginous stroma, I think of pleomorphic adenoma. This is a classical history of Sjogren's syndrome, and all these, can I call all these cells here as small round blue cells or lymphocytes? They are lymphocytes, right? All of them are lymphocytes. The lip biopsy was also a clue, right? You don't take a lip biopsy in case of pleomorphic adenoma. What's the most common site of pleomorphic adenoma? Which salivary gland? Undoubtedly parotid, right? Parotid is definitely the most common site. Lip biopsy is a diagnostic biopsy for minor salivary glands to look for Sjogren's syndrome. And you have a score here. This also came in one of the INICT exam. There's a score called focus score. Focus score helps us to score in case of a Sjogren's syndrome, which is done in a lip biopsy, right? Perfect. Okay, let's go to the next image. Diagnosis, spotter. This patient came to the OPD with a sudden collapse. This is a postmortem finding of a lung. Great, Jane. That's a classical example of a saddle embolus. Okay, saddle embolus is something which obstructs your main branch of the pulmonary artery. This is your pulmonary artery which is being separated, and that's your embolus here. It's stuck here like a saddle, so it's called as a saddle embolus, right? So in case of a pulmonary embolism, just few words about pulmonary embolism. Okay, what's the common finding in pulmonary embolism in ECG or clinical? What will be the common finding? I don't know the exact ECG finding, but I'm sure that this finding will be there. You'll have tachycardia. The most common finding in case of pulmonary embolism is just tachycardia. You'll have those SQ, so many things in ECG. I'm sure you will be well versed about it, right? Perfect. So in addition to that, if I have to do an investigation of choice for pulmonary embolism, a blood test, what will be the blood test? Blood test, pulmonary embolism, S1Q3T3. Yes, perfect. I mean, CT angiogram, I asked for a blood test, right? CT angiogram is definitely right. A blood test, I'll look for a D dimer, right? Please do remember, think of D dimer as the investigation of choice for any thrombotic disorder, be it your pulmonary embolism, be it your deep vein thrombosis, be it your DIC, anything which is thrombotic disorder, D dimer is the investigation of choice. CT angiogram, perfectly right. Since it's a blood test, it's going to be D dimer, right? Perfect. Now, can anyone give me the right diagnosis here? I'll start giving you clues. Let's arrive to the diagnosis. Few easy, maybe one bouncer here and there. What do you think is the right thing here? Comment whatever comes to your mind. You might be right, you might be wrong, doesn't matter here. Coarse stippling. Okay, you think Dr. Jane is thinking of a basophilic stippling? Perfect. Basophilic stippling will be seen in RBCs or WBCs, Jane? For everyone who's talking about basophilic stippling, lead poisoning and cirrhosis, will be seen in RBC or WBC? It will be seen in RBCs, right? So this is a WBC, right? Obviously, you know for a fact that this is a WBC. You are in the right direction. I'm having a classical coarse tickling. It's not a multiple myeloma. I'll give you a clue for this patient. This patient presented with immunodeficiency. That's a clue here. I'll add one more clue. This patient also has a very hypopigmented or a pale patch in the face. Kind of a toxic granule, but that toxic granule will not be this prominent. Immunodeficiency, hypopigmentation or albinism in the face, peripheral neuropathy. I'll take whatever options you're saying. I'll give a clue for them as well, but anything? Perfect. That's a classical case of this what you look, the WBC prominent granules in case of a Chidiac-Higashi syndrome, right? Okay. So I'm sure we must have read about Chidiac-Higashi syndrome's prominent granules. That's how a Chidiac-Higashi syndrome prominent granules looks like. Perfect. Now someone talked about toxic granulations. See, toxic granulations will be the same appearance, but it will not be this prominent. They'll be lighter, right? They'll be lighter than the above. But yes, toxic granulation also will be more granular in a neutrophilic lineage only. Next, someone called about a pseudo-Pulgar-Huet cell. I hope that's what you asked for, right? A pseudo-Pulgar-Huet cell will just have a bilobed neutrophil. Just a leading question. Tell me in which condition you can have pseudo-Pulgar-Huet cells. Which condition you can have pseudo-Pulgar-Huet cells? You can see it? Perfect. I can see in case of myelodysplastic syndrome. Please do remember, pseudo-Pulgar-Huet cells or Pulgar-Huet anomaly will not have thick granules. It will have very light granules. Toxic granulation will be a little bit lighter. If you have a history of immunodeficiency with very coarse granules, think of a Chidiac-Higashi syndrome, right? Perfect. Spotter. I'm enjoying this. You guys are amazing, right? Spotter. That's a classical apple green birefringence, right? Who will not write this? So a few leading questions regarding amyloidosis. What's a stain which is done to pick up apple green birefringence? The stain done? It is your Congo red. No doubt it has to be a Congo red, right? So which microscopy you will see apple green birefringence? It's there in the name, birefringence. So we have to have a polarized microscopy. Just a leading question from polarized microscopy. If I say in a polarized microscopy, you are seeing positive birefringence, what could be a most common diagnosis? Not fluorescent Alaganandan, it's polarized microscopy, fine. Positive birefringence, think of a silica granule. Needle-shaped negative birefringence, think of needle-shaped crystals. Negative birefringence on a polarized microscopy, think of Gouty arthritis, right? So these are the only three uses of a polarized microscopy which I can use in diagnostic pathology, right? Perfect. Now, if I use the same congruent stain and I don't have a polarized microscopy, what will be the color? What will be the color of congruent in light microscopy? You'll have your salmon pink color or orangish color. That's what you see here. Salmon pink or orange color in case of a congruent, right? Just few more things. What's the most common type of amyloidosis? Few things in and about amyloidosis. Amyloid, you have AL amyloid, which will be the common type. A is fastly increasing over the period of time. Okay. What's the most common organ associated or involved in amyloidosis? Most common organ? Perfect. It is kidney. Renal tissue is the common organ involved because AL amyloidosis is the common amyloidosis, right? What's the most common cause of death in amyloidosis? Just to complete, death. Renal failure will not cause death because we can easily manage with hemodialysis and if possible can do a renal transplant, right? Most common cause of death is almost always due to cardiac involvement. Okay, so only cardiac involvement will cause death. Infection, no, when cardiac amyloidosis is involved, it causes arrhythmias, it causes restrictive cardiomyopathy, and I may lose the patient, right? So these are few words regarding amyloidosis. Just one final point in amyloidosis. What's the most preferred site of biopsy in amyloid? Most preferred site of biopsy. Preferred site of biopsy, abdomen fat pad, right? Abdomen fat pad aspirate is the most preferred site. It's easy to do. It's easily repeatable. I can do a rectal biopsy. I can do any part. It's abdomen fat pad, the most preferred site, right? Amazing. Okay. Might be a little bit difficult, but I'll definitely give you clues. Tell me what this is. Maybe I'll zoom this image here. Maybe I'll draw something also to help you guys. Cytoplasm kind of looks like this. Can anyone tell me what cell is this? Amazing, Akshay. That's a classical Downey cell. Perfect. Where do you guys see Downey cell? That's your classical ballerina skirt appearance and a Downey cell. You see in your EBV, infectious mononucleosis, EBV, right? Again, a leading question regarding EBV. EBV can enter a B lymphocyte via which receptor? It's a wavy cytoplasm. That's why you guys said it's ballerina skirt appearance because the skirt looks like this, right? Kind of that. So it's called a ballerina skirt appearance. Your CD21 or your CR2. Complement receptor 2 is the other name for CD21 because they're asking other names in your exams, right? ERBB1, HER2 new, HER1, everything came. So CR2 is the other name for CD21, fine? So now just a question. This lymphocyte, Downey cell, is a B lymphocyte or a T lymphocyte? Whatever I see in microscopy here, is a B cell or a T cell? Obviously, your drug of choice, kissing disease. It's a B cell or a T cell. This is a T lymphocyte. See, remember, this is not the infective cell. This is the cell which is going to provide me protection, or this is an activated lymphocyte which provides me protection against the EBV. This is a T lymphocyte, right? Not B lymphocyte, this is a T lymphocyte, right? Perfect. Those are few informations regarding your Downey cell. Okay. Now next. Organ is liver. Spotter. What comes to your mind first? Liver, gross. What comes to your mind first? Organ, liver. I said right. Okay. Niche. It's not nutmeg liver. This is not nutmeg liver. This is a classical thing. What Yes said. This is a classical sign of metastasis. Please remember, whenever you have any organ, be it a lung, be it a liver, be it CNS, be it heart, if you see well-defined areas, you think of metastasis. Multiple tiny spots like this, tiny round, think of metastasis. Might not be caseation because caseations will not be very flat. It will kind of crumble. That's a clue here. Why not nutmeg is? Nutmeg liver, it's not going to be patchy like this. Nutmeg will be uniform. I'll definitely share nutmeg liver with you guys soon. Nutmeg will be there, but nutmeg will be uniform across. So that might be a clue for you to pick up nutmeg liver, right? It'll be uniform colors of red and pale areas. That's what you see nutmeg liver, right? Perfect. Just a leading question. In which condition do you see nutmeg liver? Yes, you'll have dot things like what your drug of choice said. That will be seen in nutmeg liver. Which condition? You see them in CVC liver, right? Chronic venous condition of liver is where you see the nutmeg liver. Perfect. Heart failure resulting to chronic venous condition of liver. Just one more thing before we complete this. In CVC of spleen, right? In CVC of spleen, what's a microscopic finding? in CVC of spleen, the microscopic finding in CVC spleen. We have a microscopic finding called as, you might have been very well versed about this during a second year Viva, Gamma-Gandhi bodies, right? Gamma-Gandhi bodies is something which is seen in CVC of spleen, same chronic venous condition of spleen. Since we read about the liver, we might leave the spleen. It's Gamma-Gandhi bodies. That's a classical finding, not gamma, fine. Okay, what's the fungus here? Spotter. First question, what's the stain used here? What's the stain used here? Stain used? Yeah, you told the thing. Yeah, it's a GMS stain, right? GMS actually should have been a little bit more blacker, and obviously organism here is undoubtedly Aspergillus. How did you guys find out it's Aspergillus? What's a clue? Aspergillus will be septate, aseptate. Aspergillus has to be septate. I hope you can see the septa here. And Aspergillus will have an acute angle branching, right? And acute angle branching, a septate hyphae is diagnostic of an Aspergillus, right? Perfect. Since we are in the place of Aspergillus, I'll take one more detour with Aspergillus. There's an Aspergillus called an Aspergillus fumigatus. It secretes a toxin. What toxin is that? Aspergillus fumigatus secretes a toxin. That's your aflatoxin, right? Aflatoxin. Aflatoxin causes which cancer? It causes not ergot, it's aflatoxin B1, it causes hepatocellular carcinoma, right? So in any stored grains, when you have lots of moisture, this fungus grows, which causes the toxin, which can result in hepatocellular carcinoma, right? Perfect. Can anyone tell me any one other stain apart from GMS, which is used to pick up fungal hyphae? One more stain apart from GMS, which can be used to pick up fungal hyphae. Fungal hyphae can be picked up in two stains. PAS, not that great. Definitely GMS is much more specific thing. PS is a little bit more sensitive, not that great, right? PS can be done as well, fine. Okay, but LCB also can be done for sure, fine. Now next thing here. Now here, I'm going to, before marking, can anyone tell me what's the diagnosis here? After that, I'll mark where to look for. Let's see if you can pick up the diagnosis before marking. You guys are amazing. You can do it. Okay, I'll mark now. This is what I want you to focus here. This is what I want you to focus here. Tell me now what's the diagnosis. Perfect. It's a classical case of mucormycosis. Okay. First thing, mucormycosis is an invasive organism or a non-invasive organism? Mucor, invasive or non-invasive? Mucor undoubtedly is invasive, right? I'll erase this here. Can you appreciate that this is a blood vessel? Someone said glomeruloid body. The reason why you confuse with glomeruloid is it's a blood vessel. It's a blood vessel. I'll zoom this here. Can you see in the wall of the blood vessel a mucus staying here? Right? So it's an invasive organism. It has gone into the blood vessel also, and it's invading the wall of the blood vessel as well, right? It's angio-invasiveness, which makes it very, very deadly. It's definitely an emergency to report. A right angle hyphae with bulbous end is classical for a mucormycosis, right? COVID, yeah, black fungus came with the COVID thing, right? Perfect. Now, spotter. This has not been asked since we are going with few PYQs if something new comes in. This is not that common in our country. Diagnosis. Babesia, right? The Maltese cross appearance. Maltese cross appearance is classically seen in your babesiosis, right? Okay. Where else have you heard about Maltese cross? Just if you not know homework, just remember wherever you use Maltese cross. Perfect. In Fabries, I can see Maltese cross, right? Amazing, great, superb. There's a blood vessel here. I want you to tell me what's the diagnosis here. This blood vessel is classically seen. We see this change in case of an hypertension. What will be the diagnosis? You can see the wall of the arteriole becoming very, very thick and pink in color. That's your hyaline arteriolosclerosis. An extremely pink color wall of the vessel is hyaline arteriosclerosis. Again, fastest finger first. In which condition you will see hyaline? Benign or malignant? Benign or malignant? You'll see them in benign hypertension, right? What will be the microscopic finding in case of a blood vessel in malignant hypertension? Microscopy, not the gross. You'll see hyaline in benign hypertension, and in malignant hypertension, you see your onion skinning or this person, right? You see this onion skinning appearance or your hyperplastic arteriolosclerosis in case of a malignant hypertension, right? Yes, you will see fibrinoid necrosis. You are right, Priyanka. This is a classical finding, the arteriosclerosis, onion skinning, or your hyperplastic arteriosclerosis, right? Just to complete this, what is the gross finding of kidney in case of a benign hypertension? The gross finding. The gross finding in kidney. You have flea-bitten appearance, right? So the gross finding in kidney in case of a malignant hypertension is your flea-bitten appearance or just petechial hemorrhages on top of the kidney. What's the gross finding in case of a benign hypertension? Gross finding in case of benign hypertension, you have something called a granular contracted kidney, right? So this is what you see in case of a benign hypertension, granular contracted smaller kidney, and in malignant hypertension, you have the petechial hemorrhages or your flea-bitten appearance, right? Great. So since we are in the onion skinning, there's one more disease which also causes onion skinning in microscopy, but it involves your biliary radicals, right? Srini, the fibrinoid necrosis is nothing but necrosis seen in the blood vessels, which also is seen in malignant hypertension, right? Perfect. This is your primary sclerosing cholangitis, which also has onion skinning appearance, right? Just a word here, primary sclerosing cholangitis involves small biliary radicals or large bile ducts. Will it involve smaller ones, bigger ones? PSC always involves larger ducts, it will not involve the smaller ones. PSC is involved with other autoimmune disorder or it's involved with ulcerative colitis. PSC always involves larger things, not smaller. Your primary biliary cholangitis involves your smaller ones, right? And here you'll have most of the time associated with ulcerative colitis, right? So you might see in this patient's ANCA positivity also, and it will be most commonly associated with ulcerative colitis, right? Perfect. Okay, these are few pointers with your primary sclerosing cholangitis, right? Okay, first question, what is the stain used here? This is a blood vessel biopsy, so what is the stain used here? Microscopy for blood vessel biopsy, the stain used here, not reticulum, not sweets, not von Cosa. It's a silver stain. I'll go with whatever Nishan said. It's definitely a silver stain. The silver stain used to identify your elastic fibers is VVG, right? It's definitely a silver stain. It's VVG. Reticulin is not used for blood vessel. It is useful for all your reticuloendothelial system, like your liver, like your spleen. I use them. I don't use them for blood vessel. It's an elastic tissue stain, right? So here in this elastic tissue stain, I'm having areas of destruction of the blood vessel. So what is this microscopic finding called? Tiny cyst-like areas of destruction in a blood vessel in an elastic artery. We call this cystic medial degeneration or cystic medial necrosis. Next question is, where do you see this? Which condition? Which condition you see cystic medial necrosis or cystic medial degeneration? Not in temporal arteritis. I'll definitely come to temporal arteritis soon. Might not be exactly in old age also. There are two options I want you to remember. It can be seen in aortic aneurysm. This might be new for you, right? Don't forget this. And also seen in case of an aortic dissection. Can anyone tell me which syndromes you will see aortic dissection? That's an easy question. Both aortic aneurysm and aortic dissection, you can see cystic medial necrosis, and you see them in Marfan syndrome, Ehlers-Danlos syndrome, and others, right? Perfect. Okay, amazing. So someone said, Srinidhi said that this could be seen in temporal arteritis. We look at temporal arteritis also. What biopsy is this? Same stain. What's happening here? Can anyone tell me what layer is this? Which layer of the blood vessel is this? This is a VVG stain. You can see a tiny black layer. It's an elastic layer. This is your internal elastic lamina, right? It's internal elastic lamina, and internal elastic lamina will be broken. When you have breaks in internal elastic lamina, that's classical diagnostic pointers for your temporal arteritis or your giant cell arteritis, right? Perfect. Since it was same BVG stain, I included that. Fine. Okay. Now, there's a gross appearance of a lung. I'm going to give you a clue first itself. I'm going to have two types of emphysema here. Let's mark 1 and 2. I'll just zoom a little bit maybe. Tell me which is centriacinar emphysema. Emphysema is right, Akshay. Which is centriacinar, 1 or 2? Centriacinar will have both normal and abnormal areas. That's a clue here. And panacinar will have only abnormal areas, which is centriacinar. Perfect. First one is centuries now, because I see both normal areas and marked as E, emphysematically dilated areas. That's your classical case of centuries now emphysema. And the second one, which is only dilated alveoli, we call it an pan-acinar emphysema, right? Amazing, great. Just one more leading question. In which deficiency or which syndrome do you have pan-acinar emphysema? Just to revise with that, you'll see them in great alpha-1 antitrypsin deficiency, right? Superb. So which of these two do you think is the most common subtype? Century or pan? Undoubtedly, century is the most common subtype. Which is more commonly involved in smoking? Century or pan? If something is more common, it has to be more commonly involved in smoking, right? Perfect. So there's one more type of emphysema called as bullous emphysema. In bullous emphysema, what will be the microscopic finding? Century acinar, pan acinar, or distal acinar? Which will be there in bullous emphysema? I'm sure you must have heard about bullous emphysema. You have distal acinar. The distal acinar emphysema is what protrudes as a bulla in the top of the lung, right? But these are a few pointers regarding emphysema which I want you to know, right? Amazing. Okay. This also is a lung biopsy. This is spotter. This is a very old NEET PYQ, not asked anytime in recent times. It's a flux which happens in your. Yes, Sahil, I wanted to ask spontaneous pneumothorax next, but I'm sure you guys know, so I ignored it. Flux of kind of organized material seen in the lungs. This is seen in case of an cryptogenic, not an SCC, organizing pneumonia. Can anyone name the structure? Cryptogenic organizing pneumonia, and these structures are also named after the same trichrome stain and the Fontana stain what we saw. This is called as Mason bodies. Fine. Perfect. So these tiny things looks like a squamous keratin pearl, right, which is obstructing the place. Cryptogenic organizing pneumonia called as a Mason bodies. It's a very diagnostic pointer, very old NEET PYQs. If it repeats, it will help, right? Okay, spotter. I want everyone online to comment on this. Let's have more of a positive attitude for the next 1 month till you have the exam. That's a classical finding of an asbestos body or ferruginous body, right? It's a classical asbestos body or ferruginous body. In your NEET exam, you also had once a Pearl's positive image as blue color structure the same way as your asbestos or your ferruginous body, right? Perfect, amazing. Okay, dumbbell shape structure, any shape structure, that's an asbestos or a ferruginous body, fine. This also is a lung biopsy. This is an old Ames repeat. A lung biopsy with completely pink color structure filling that. This is not a pleural effusion. This is your perfect. This is a very old one. Can anyone tell this? Srinidhi is right. It's not ARDS. I'll come to ARDS, Rahul C. It's not an hyaline membrane disease. I'll tell you how to differentiate this and a hyaline membrane disease. Then pulmonary alveolar proteinosis, right? This is a very old repeat. It has not been asked till now. It's pulmonary alveolar proteinosis where the entire alveoli, it's entire alveoli. That's a clue here. If your entire alveoli is filled with pink material, a protein-like material, it could be a surfactant problem or it could be a macrophage problem. It's called a pulmonary alveolar proteinosis. And very old PYQ. I hope if it's repeat, it'll be of help for you. Some of you said it's an ARDS or an hyaline membrane disease. The main difference between ARDS and this is ARDS alveoli will look like this. The center part will be clear in ARDS. You'll have only the peripheral lining. It's a hyaline membrane, right? It's just a membrane of hyaline, not entire thing. Entire alveoli is pink color. It's pulmonary alveolar proteinosis. Otherwise, it's a hyaline membrane disease, right? Great. Spotter. This is seen in one of the subtypes of lung adenocarcinoma. This pattern for the first person who saw, it looked like butterflies sitting on a line. Yeah, your SPP mutation type 3, everything is right. It's an what pattern? Yeah, it's adenocarcinoma in situ or an lipidic pattern of spread, which is seen in adenocarcinoma in situ. The older PYQs, bronchial alveolar carcinoma, it's not being used anymore. It's adenocarcinoma in situ. KK, I think you're predicting my next question. This is not an asoparty effect. This is an adenocarcinoma in situ lipidic pattern. The main difference between adenocarcinoma in situ versus adenocarcinoma, what's the only difference? What's the only difference between adenocarcinoma in situ and adenocarcinoma? It's invasion, right? So it's very difficult for an undergraduate to pick up invasion. If you see the pink interstitium in between two alveoli, it's invaded. If you don't see, like this is an alveolar membrane here, I don't see the pink interstitium, so I call it an in situ lesion, right? Amazing. Okay. Again, one more image from lung cancer. Diagnosis. This is a blood vessel. Blood vessel surrounding area, I have lots of blue color deposit. What is this? KK told this answer previously itself. This is your classical Azzopardi effect, right? KK, I hope you will be able to differentiate this. Azzopardi will be blue smudged DNA, and this is cells sitting on a line. That's how you have Azzopardi effect. You will see in your small cell carcinoma of lung. Few more leading questions in small cell carcinoma of lung. Small cell carcinoma of lung previously had one old name. Because of the shape of the cell, it looks a little bit elongated. What's the name? It was also called as an oat cell carcinoma of lung. We don't use this anymore, right? Small cell carcinoma of the lung. What are the paraneoplastic syndromes seen? Can anyone tell me at least one paraneoplastic syndrome seen in small cell carcinoma of lung? Srinidhi, I'll come to your point as well. P40 and P63 is positive in squamous cell carcinoma, not in small cell carcinoma, right? You see Cushing syndrome. You can see SAADH, syndrome of inappropriate ADH secretion in small cell carcinoma of lung, right? And any markers you guys know in small cell carcinoma of lung? Small cell carcinoma is one which can have multiple n number of paraneoplastic syndromes, right? You have synaptophysin, you have chromogranin, and this INICT you had one nuclear marker, might not be required, but these are more than enough. CD56, NSC. Synaptophysin chromogranin is something which I don't want you to forget. That's a commonly used one. And other things are just out of the boxes. Fine. Perfect. Okay. Heart. What's the stain used here? Stain used here. Just 3 more images and let's wind up. The stain here is your triphenyl tetrasodium chloride, right? Where do you use this? In which condition? You use this to diagnose the postmortem appearance of a myocardial infarction. TTC is the thing what you use. It's not toluidine, it's triphenyl tetrasodium chloride, right? I have 3 pointers here. Let's mark 1, let's mark 2, and let's mark 3. Which of these 3 is a scar tissue? 1, 2, or 3? Which is scar tissue? Obviously, third is a scar tissue. When something is completely white in color, extremely white, it's scar tissue, right? 2 is not scar, 3 is scar. Which is normal myocardium, 1 or 2? Perfect. 1 is normal myocardium, right? And what is 2? 2 is your necrotic area, right? The coagulated necrotic area will be pale in color, normal myocardium will be red in color, and white color, completely white color will be a scar tissue, right? Amazing, okay? Diagnosis, Potter. This is your gross vegetation, tiny vegetations here, and this structure is your Ashoff body. I don't know, but still people are hell-bent on asking Ashoff body in case of rheumatic heart disease. I am sure you will write this. There will be no doubt in Ashoff body, right? Few words about vegetation. Which is the only infective vegetation seen? Which is the only infective vegetation seen? It's infective endocarditis. Apart from that, every vegetation is sterile. Only infective vegetation is infective endocarditis, right? Which is the only vegetation which is seen on both atrial and ventricular surface of the valve. Which vegetation is seen on both atrial and ventricular? It's your Libman-Sachs endocarditis, right? Which is the only vegetation which can undergo an embolic transformation, which can become an embolus. Again, it's your infective endocarditis, right? Which vegetation is also called as an verrucae? Is it rheumatic, NBT, infective, or your Libman-Sachs? Verrucae is your rheumatic heart disease or rheumatic vegetation. They are very, very tiny, like a verruca vulgaris, like a wart, so we call it a verrucae, right? Verrucae is your rheumatic heart disease. Infective endocarditis is both infective and fragile, and they can become an embolus. On both sides of the valve, you have your Libman-Sachs endocarditis, right? Perfect. Okay. Spotter. This is a classical spotter. This came in your NEET PG exam. We did study Rahul. Okay. This is your banana shaped appearance or your banana shaped ventricle. Okay. And this is your asymmetrical septal hypertrophy. Both of them are classically seen in which condition? It's seen in HOCM, right? Perfect. Asymmetrical septal hypertrophy and a banana shaped ventricle, classical diagnostic feature of HOCM, right? And what's a microscopic finding of HOCM? You have all the fibers going in a very different direction. We call it a myofiber disarray, helter-skelter pattern, or a myofiber disarray. Helter-skelter is here and there, that's all. And one more finding in HOCM, which is non-specific. That's called as a boxcar nuclei. If you look at this nucleus, it looks like a good strains compartment. So we call it a boxcar nuclei. Boxcar nuclei is a very non-specific finding. I can see them in any hypertrophy, even in your cardiac hypertension induced hypertrophy. You can see the boxcar appear, right? Okay, the last image, and an easy image. This is an esophageal endoscopic finding. Diagnosis: esophagus, endoscopy, diagnosis. That's your feline esophagus. You see in case of an eosinophilic esophagitis, right? You see in eosinophilic esophagitis, a classical feline esophagus, right? Perfect. So we'll wind up today. I'll definitely come up with one more session which will include the rest of whatever systemic pathologies left, like kidney, FGT, MGT, and also hematology, right? Okay. So you guys, amazing. Let's go and revise and keep the momentum going. I'm 100% sure you'll do well. Ignore the INACD ranks, push it forward, stay out of social media as much as possible, and let's learn again. Fine. Okay. Yes, your drug of choice. Rahul, I told you, we did read about vegetations in our batch as well. Fine. We'll do it, your drug of choice. We'll do it again soon. Fine. Okay. Bye-bye. Thank you.